Hello, this is Jesse Gamez, and I'm pleased today to start with my case with Lowell's Community Hospital. This is my capstone project, and today is June 13, 2017. So let's do an overview of the Lowell's Hospital. It's a 217-bed hospital located outside Boston, Massachusetts. It owns a surgery center and an MRI. It has 2 satellite facilities. In May of 2007, did an additional 190,000 square foot addition. That addition had new spaces for surgery, mother, baby, emergency room, trauma, and medical, surgical, private rooms. The stated goal of that expansion was to improve the hospital reputation in the community. Stewart Health System is the main competitor in that Lowell's community. The average Lowell's community is an average per capita income is $22,800, which, as you can see, compared to the state average, is lower. Also has 98% of the group is insured. They have a higher prevalence compared to the state in both diabetes, heart disease, and frankly, all of their other health measures are lower. They also have a higher prevalence of smoking in Lowell's community. So in general, I'm going to talk about healthcare has its problems, and I like the saying, and I think it plays out to be true. We in healthcare think that we are doing really well, and we are the cream of the crop, according to Donald Berwick. We also have seen that the U.S. lags behind many industrial countries in outcomes and leads in the total cost, according to the Commonwealth Fund. There is a divergence of opinion on the solutions to our cost problems, and I would say that Lowell's hospitals face similar problems at the macro level. So what's the root cause of Lowell's problems? Well, Lowell's wants to meet the Blue Shield accountability quality contract. Their top challenges are that they have leakage of 40%. They're seeing their medical costs declining 3 years in a row. They're seeing quality improve, declining margins, and they're really structured as a fee-for-service organization. Generally, you'd be okay with medical costs declining. However, if you're a fee-for-service organization, it depends on the revenue coming in. Then declining medical costs basically means declining revenue. So what options in the case does the Lowell's community hospital? Actually, I have 3, in my opinion. Number 1 is that they can choose to exit the Blue Cross AQC totally and end the contractual relationship with the Blue Cross plan. 2, they can choose to stay the course with AQC and design their delivery system to make the necessary improvements to make the contract financially viable. Or the 3rd option is that they can choose to modify its relationship with Blue Cross and pursue other partnerships. So I've done a little pros and cons grid here for you to see sort of the pros and cons of each one of them. Option 1, staying status quo. There's no short-term pressure on the organization. They can reduce their overhead costs. They don't need to run an AQC. And of course, their specialists will be happy since they've had some dynamic between primary care and specialty in terms of referrals. Option 2 is where they can basically continue status quo and really try to make the AQC work. That actually has many positive benefits, from improving quality and cost to moving the organization from a volume to value-based organization. They can redesign themselves. They can look at reducing 40% of leakage, and they can improve their market position. And option 3 is sort of a blend of option 1 of option 2 and option 1. That really is they can improve quality, lower their cost, and they can move from volume to value contracting. So what are the cons of option number 1? Not moving from volume to value is a con. Higher cost, and of course the structure in terms of just keeping it the same. Cons of option number 2, which is maintaining their current structure and then moving forward with a redesign effort, requires leadership. That's going to require leadership to put the organization sort of on notice that they're going to make changes. It's going to put pressure on the administrative team to be able to do the redesign efforts, and it's going to require a redesign. And the cons to option number 3 is it requires, again, leadership. There would be more risk introduced if we were to add additional partners, and that can be a risk, not to mention risk from a financial perspective and an operating perspective. So what's Lowell's strategic opportunity here in this case? One is that they can define, develop, and sustain the organizational value. So they can really hone in on what they are good at and where they produce that value. They can produce differentiation. How can they differentiate themselves in the marketplace? They can focus and align their resources. They can develop understanding and commitment of their leadership team around making value-based care work. And then they can drive effective accountability into the line to make sure that they're meeting the requirements of their value-based contracts. Did a little SWOT analysis here, and I think that this shows the strengths, weaknesses, opportunities, and threats for Lowell's. As one can see that they're currently, the positive thing with Lowell's is they have a positive margin. They're improving quality, year-over-year quality. They have a good ratio of primary care and specialists, and they are a low-cost provider. Weakness is they are seeing decline in their margin. They're a small hospital. They have a small hospital network. They do, as we saw earlier in the slides, a higher illness burden and population health. They also could be having a health literacy problem, and they do have 40% leakage. From an opportunity perspective, one can say that reduction in cost is an opportunity, capitalizing on the rising quality scores is an opportunity, maximizing utilization of newly remodeled hospital is an opportunity for them, driving volume to outpatient services, and meeting shared savings with no additional volume. If they're not seeing patients and reducing their costs, that actually is money that one can argue is free. And the threats in the marketplace are, of course, they've had some infighting with their PCPs and specialists. They do have larger competitors who are more dominant in the market. They are seeing market consolidation. And Blue Cross will have a contract with hospitals. One of the other things that I wanted to discuss as part of a framework of this AQC and keeping Lowell's in the game is that, according to Gershner, what we're seeing is really a pressure and divergence of commercial Medicare and Medicaid all moving towards payment reform. Value-based care, for instance, is a opportunity. So we need to continue to focus on the fact that the marketplace is moving in this direction. Why do we want to do this? Of course, the market's changing rapidly. We want to take advantage of the leadership's willingness to move. We want to move from volume to value. We want to support providers through this change. And Blue Cross, frankly, wants to reduce their costs and improve their quality. So what are some potential barriers? The process will be, the ACO process can be complicated in terms of using the tool from CMS, the Innovation Center. Ensuring alignment and organizational strategic goals are met. Addressing cross-functional cultural barriers can be a potential barrier. Tension between primary care and specialists, and we must make them feel supported according to West. And they do have a lower reputation in the community. So I put together some solution criteria and to ensure that we're going to meet the goals of Lowell's. One is to make sure that there's a positive impact on the margin, positive impact on the reputation, that we reduce leakage, that we bend the cost curve, that we improve staff utilization, and that we manage our supply costs, because that is an opportunity across all organizations according to bending the cost curve best practice. So what solution should Lowell's take? The organization could choose to stay the course with the AQC and redesign its delivery system to make the necessary improvements to make the contract financially viable is the solution alternative that I'm proposing. Overall, we need to improve their margin over the next several years. They need to reduce leakage. They need to improve quality scores. That's what the graphs are showing. We're going to have to create an implementation team that's comprised of a senior sponsor team, a finance team, clinical design, quality improvement, and you can see the other teams. The important point on this slide is that it's going to be about a 8 to 10 week process. We're going to have operational leaders involved with strong support teams. So what are the teams going to be looking for? What are we going to look for them for in terms of criteria? We're going to want them to set realistic expectations. We want to make sure that they have good communication expectations. We're ensuring alignment with organization's strategic goals, that we're holding the teams accountable for outcomes. We use quality improvement tools, and that they address cross-functional culture barriers that's going to make a successful team. Key considerations for the team will be that they need to improve an operating performance. They need to recognize and understand the key drivers, costs. They need to make sure that they recognize that it's important for us to have a stable medical staff, Lowell's is interested in consumer engagement. They've invested a lot of money and resources in the hospital, and they want to make sure that they have consumers that are using their system and reducing leakage. And of course, we want to make sure that all decisions are data-based and driven by data. And so having a strong data will be important for each of the teams to meet their objectives. I did put it together here. You can see this is a report out process where each team will have a reporting. And it looks, I know it's a little small here, but the basic premise is that on every team, when their leader will have report out criteria and deliverables, and that deliverables will need to be both. We'll have a beginning implementation team meeting that gets all the teams set. They'll have check-ins every week, either written or in person. They'll have a mid-process check-in with a report out, a conclusion checkout process where we're basically everybody's going to see what their recommendations are, and this will make sure that we continue to have alignment post-implementation of the project. So what does the future state look? In the middle, I put the operational redesign is going to occur. We'll see that post-leadership must change in order to be able to be successful in this new world of value-based care. We're creating a true systematic integration. We're looking at capitalizing on our efficiency. And I talked about their overall that they have had a higher number of people in their population who have diabetes and other chronic conditions. Perhaps what they need is some additional work in health literacy, so we expect that the quality and the clinical team will address these issues, and so we can maximize the work. So in conclusion, Lowell's can and will be successful. The system cannot avoid changing. Cost must be controlled. Leadership needs to transform the system. Operational disruption will occur. Lowell's must focus on re-engineering their system. And payment reform is coming, and this recommendation will help Lowell's deal with that because we're moving from a volume-based to a value-based system. And I appreciate all of you hearing me today. For your reference, these are my references. Thank you and have a good night.